Good day! Today, we're going to talk about urine concentration and dilution, along with the regulation of extracellular fluid osmolarity and sodium concentration. Before we begin our discussion, I would like to ask you some questions. When you saw and heard the title, what was your idea that popped out in your mind about our topic for today? Is it about the mechanism of the kidneys for its urine concentration and dilution? Or regulation of extracellular fluid osmolarity and sodium concentration by the renal tubules? Or, nonetheless, how boring the topic would be. But with all of these ideas, have you ever thought of asking, are the kidneys really the one who controls all of it? Or is there a hormone involved? Or how do the topics relate with each other? And in order to answer all of these questions, let us learn the topic together. To ensure that we have the same goals in mind, we have prepared a list of objectives. So A. To understand the mechanism of urine concentration. B. To determine the contributing factors of tubular segments involved in urine concentration. C. To understand the osmoreceptor ADH feedback system. D. To understand the importance of thirst mechanism. E. To differentiate hyponatremia from hypernatremia. F. To understand and classify the different diuretics. And lastly, G. To understand the mechanism of natriuresis. So now, let us begin our discussion.
We know that the body has a powerful feedback system for regulating plasma osmolarity and sodium concentration, which operates by altering renal excretion of water independently of the rate of solute excretion. And the primary factor of the said feedback is the antidiuretic hormone, which is also known as vasopressin. This hormone is a substance that decreases urine production. This causes the kidneys to return more water to the blood, thus decreasing urine volume. Hence, the antidiuretic itself. Now, for example, when osmolarity of the body fluids increase, the posterior pituitary gland secretes more of this hormone, increasing the permeability of the distal tubules and collecting ducts to water. This causes an increase in water reabsorption and decreasing urine volume. In contrast, when there is excess water in the body, and of course there's a reduced extracellular fluid osmolarity, the secretion of this hormone is also reduced, reducing the permeability of the distal tubule and collecting ducts to water. This causes an increased amount of more dilute urine to be excreted. After knowing the effect of the antidiuretic hormone to the distal convoluted tubule and collecting tubule, we can now understand how this hormone can result to a diluted urine or a concentrated one. As you can see in the left figure, just focusing on the distal and collecting tubules, you can see that there is less solute concentration. This is due to a very low level of antidiuretic hormone. In contrast, you can see in the right figure a concentrated urine, specifically in the distal and collecting tubules. Now this is due to the presence of a high level of antidiuretic hormone. Later, we will be discussing how is this hormone regulated or what factors affecting its secretion. Remember that the glomerular filtrate, when initially formed, its osmolarity is about the same as that of the plasma, which is 300 milliosmoles per liter. Now let's go to the renal mechanisms for excreting dilute urine, and what happens in the renal tubules during this time. First is that, in the proximal tubule, it remains its tubular fluid isoosmotic fluid because of the fact that the solutes and water are reabsorbed in equal proportions in this section, so little change in osmolarity occurs. The proximal tubule fluid remains isosmotic to the plasma with an osmolarity of about 300 milliosmoles per liter. Now, as the fluid descends down the descending loop of Henle, water is also reabsorbed by osmosis, making this fluid equilibrium with the hypertonic renal medullary interstitium. Next is that, in the ascending limb of the loop of Henle, especially in the thick segment, ions such as sodium, potassium, and chloride, they are avidly reabsorbed. But even in the presence of a large amount of antidiuretic hormone, this tubule is impermeable to water, which means that the fluid becomes more dilute as it goes through this tubule and into the early distal tubule, with the osmolarity decreasing to about 100 milliosmoles per liter. As the dilute fluid in the early distal tubule passes into the late distal convoluted tubule, cortical collecting duct, and collecting duct, there is still an additional reabsorption of sodium chloride. In the absence of antidiuretic hormone, this portion of the tubule is also impermeable to water, decreasing its osmolarity to as low as 50 milliosmoles per liter. Now remember that the fluid leaving the ascending loop of Henle and early distal tubule is always dilute, regardless of the level of the ADH. In the absence of ADH, the urine is further diluted in the late distal tubule and collecting ducts. Thus, a large volume of dilute urine is excreted. After discussing the renal mechanisms for excreting dilute urine, let us now discuss the basic requirements for excreting concentrated urine. The first basic requirement is a high level of antidiuretic hormone. This high level will increase the permeability of the distal tubules and collecting ducts to water, allowing an avid reabsorption of water. Next would be a high osmolarity of renal medullary interstitial fluid. Now, the renal medullary interstitium is normally hyperosmotic, which provides osmotic gradient necessary for water reabsorption to occur, of course with the presence of a high level of antidiuretic hormone. In addition to the statement I told you before that the renal medullary interstitium is normally hyperosmotic, this is the reason why. The process involves the operation of what we call the countercurrent multiplier mechanism. This mechanism depends on the special anatomical arrangement of the loops of Henle and the vasa recta, and there are some steps that are also involved. But before discussing one by one, let us first know the factors affecting this mechanism. Now, first factor is the active transport of sodium and co-transport of potassium, chloride, and other ions out of the thick ascending limb of the loop of Henle. Next is an active transport of ions from the collecting ducts going to the medullary interstitium. Third, the facilitated diffusion of urea from the inner medullary collecting ducts going to the medullary interstitium. Next is the diffusion of only small amounts of water from the medullary tubules going to the medullary interstitium. Now here are the steps that are causing the high osmolarity of the renal medullary interstitium. Please refer to this figure as we discuss each of the steps. Now, as you can see in the first picture, this shows the loop of Henle being already filled with a fluid with a concentration of only 300 milliosmoles per liter, which is similar to that of the proximal tubule. Now, knowing that the thick ascending limb has these active ion pumps, which causes solute to go outside of the tubule, this reduces the concentration inside and establishing a 200 milliosmoles per liter concentration gradient between. And there you can see in the next picture. Note that the limit to the gradient is about 200 milliosmoles per liter because paracellular diffusion of ions back into the tubule eventually counterbalances transport of ions out of the lumen when the 200 milliosmoles per liter concentration gradient is achieved. Now, as you can see in the third picture, we can see the osmotic equilibrium between the tubule and the interstitium in the left side. This is due to the fact that the descending limb of the loop of Henle is actually permeable to water, causing the tubular fluid and the interstitial fluid quickly reach osmotic equilibrium because of the osmosis of water out of the tubule. But because of a continued transport of ions out of the thick ascending limb, the interstitial osmolarity is maintained at 400 milliosmoles per liter. Since there is still of course a continuous flow of fluid from the proximal tubule into the descending limb, and then towards the ascending limb of the loop of Henle, additional ions are being pumped out into the medullary interstitium, rising the concentration into 500 milliosmoles per liter, with of course a 200 milliosmoles per liter osmotic gradient, as you can see in the picture number 5. Because again of this descending limb causing an osmotic equilibrium between the tubular fluid and the interstitial fluid, you can see in the sixth picture the same concentration between the left tubule and the interstitial fluid. As fluid from the proximal flow into the descending limb and upward toward the ascending limb, more solutes are being pumped out to the interstitium, and these steps are repeated over and over again. This process gradually traps the solutes in the medulla, multiplying the concentration gradient, raising the interstitial fluid osmolarity to 1,200 to 1,400 milliosmoles per liter, and thus the mechanism called the countercurrent multiplication, being the loop of Henle as the countercurrent multiplier. Now specifically, what could be the role of the loop of Henle in making the medullary interstitium to have high osmolarity? It was discussed from the previous discussions about the reabsorption capacity of the loop of Henle, as it is a tubule situated in the medulla, right? Now it was mentioned there that the thin ascending limb has some passive reabsorption of sodium chloride and is impermeable to water. So if this is the case, what do you think will happen to the interstitium when these solutes go out without water? In addition, the thick ascending limb of the loop of Henle has the active transport of sodium and co-transport of potassium, chloride, and other ions, and is also impermeable to water. Note, these two characteristics of loop of Henle make the medullary interstitium to have high osmolarity. Now, what could be the role of the distal tubule and collecting duct? We were able to learn that the tubular fluid coming from the loop of Henle is diluted, since the solutes are being pumped out to the interstitium, leaving the water not reabsorbed. Note of the concentration only being 100 milliosmoles per liter, which is being further diluted by the early distal tubule due to its similar mechanism with the thick ascending limb. Antidiuretic hormones, by binding to the receptors on cells in the collecting duct, make the water reabsorbed into the cortex interstitium specifically, preserving the high medullary osmolarity still, although there is also water reabsorption in the medulla, but is relatively small. Now take note that the urea as a waste product that is needed to be excreted out from the body can also help or contribute in the hyperosmotic renal medullary interstitium by about 500 to 600 milliosmoles per liter. This is possibly reabsorbed from the tubule, especially when blood concentration of ADH is high. By how it is reabsorbed? Now, in the distal tubule and cortical collecting tubule, since urea is impermeable here, only little urea is reabsorbed. As the tubular fluid flows into the inner medullary collecting ducts, more water is being reabsorbed, causing a higher urea concentration, which causes the urea to diffuse out of the tubule into the interstitium, facilitated by its own urea transporter, or the UTA 1 and UTA3, which are all activated by ADH. Note that in proximal convoluted tubule, 40 to 50% of the filtered urea is reabsorbed here. But in the case of the thick limb of the loop of Henle, until the cortical collecting tubule, urea is impermeable, so very little is reabsorbed here. But as the urea flows into the inner medullary collecting duct, high concentration of urea and the urea transporters cause it to diffuse into the interstitium, which then eventually diffuse into the thin loop of Henle, then passing upward through the ascending loop of Henle until it gets back to the medullary collecting duct again. This recirculation is important especially when there's low blood volume. Remember that this renal medullary interstitium having a high osmolarity helps the kidney to reabsorb water when the blood volume in the body is low. Now, what maintains the medullary hyperosmolarity that prevent it from being dissipated? It is the vasa recta. This is a long, thin-walled vessel that parallels the loop of Henle of the juxtamedullary nephrons. This is a U-shaped capillaries. Now, they keep the salt pumped out of the ascending limb of the loop of Henle to remain in the interstitial fluid. The vasa recta also serve as a countercurrent exchangers, minimizing wash-out of solutes from the medullary interstitium. Blood enters and leaves the medulla by way of this vasa recta, located at the boundary of the cortex and the renal medulla. Like other capillaries, it is highly permeable to solutes except for plasma proteins. Remember, as it descends into the medulla toward the papilla, it becomes more concentrated. Due to solute entry from the interstitium and water loss, it begins at 300 milliosmoles per liter and progressively makes to 1,200 milliosmoles per liter at the tip and revert back to 300 as it goes up. This results in large amount of fluid and solute exchange. This U-shaped structure helps minimize loss of solute from the interstitium. But when there is a low level of antidiuretic hormone concentrations, the medullary interstitial osmolarity is now less than 1,200 milliosmoles per liter, forming a dilute urine. Now, as for the thick part of the ascending loop of Henle, because this is impermeable to water but are actively transporting large amounts of sodium chloride potassium into the medullary interstitium, therefore, fluid here becomes very dilute, falling to a concentration of about 100 milliosmoles per liter. Now remember that the early distal tubule has the same properties with the thick ascending limb, diluting further the fluid to 50 milliosmoles per liter. But as for the case of the late distal tubule and cortical collecting tubule, this depends on the level of the antidiuretic hormone. If this is high, this causes a significant water reabsorption, but if absent, little of this water is reabsorbed. Lastly, in the concentration of fluid in the inner medullary collecting ducts, this depends on two, the ADH and the surrounding medullary interstitium osmolarity, which is established by the countercurrent multiplication that we discussed before. With the presence of large amounts of antidiuretic hormone, water diffuses from the tubule into the interstitial fluid until an osmotic equilibrium is reached. Thus, a small volume of concentrated urine is produced. Because water reabsorption increases urea concentration in the tubular fluid, and remember that the inner medullary collecting ducts have specific urea transporters, so these transporters would greatly facilitate diffusion. Much of the highly concentrated urea in the ducts diffuses out of the tubular lumen into the medullary interstitium. This absorption of urea into the renal medulla contributes to the high osmolarity of the medullary interstitium and the high concentrating ability of the kidney. Now, before we end the discussion about the ability of the kidneys to excrete a concentrated or dilute urine, here are some of the important points. First is that the kidney can excrete a highly concentrated urine that contains only little sodium chloride when needed. This is because there are other solutes that are highly concentrated, maintaining the hyperosmolarity of the urine. Next important point is the large quantities of dilute urine can be excreted without increasing sodium excretion. This is done by decreasing ADH secretion, reducing water reabsorption in the more distal tubular segments without significantly altering sodium reabsorption. Now lastly, there is an obligatory urine volume dictated by the maximum concentrating ability of the kidney and the amount of solute that must be excreted. Now, have you ever asked yourself how can we actually quantify the renal urine concentration and dilution? This is actually with the involvement of these two concepts, the osmolar clearance and the free water clearance. Osmolar clearance is the rate at which solutes are cleared from the blood. It is a measurement of the volume of plasma cleared of solutes each minute. Now we can calculate this by using this formula C equals U times V over P, as C is the osmolar clearance, U as the urine osmolarity, V as the rate of urine flow, and P as the plasma osmolarity. Now the next concept is the free water clearance. This is the rate at which solute-free water is excreted by the kidneys, which means that the water is free of solutes. Now we can calculate this with this formula, C equals V minus C. As you can see, we have two C's here, but the first C is actually the free water clearance. The second C is just the osmolar clearance, while V is the rate of urine flow, which means that free water clearance is defined as the difference between water excretion or urine flow rate and the osmolar clearance. As you can see, when there is a positive value, this indicates that excess water is being excreted by the kidneys, forming a dilute urine. On the other hand, a negative free water clearance means that there is an excess solutes being removed by the kidneys, conserving water and concentrating the urine. We always hear this term specific gravity as a part of the results routinely released on urinalysis. So what does this specific gravity result really mean? Specific gravity is a rapid estimate of urine solute concentration, which means that when there is a high concentrated urine, there would be a high urine specific gravity result. This is also a measure of weight of solutes in a given volume of urine, thus determined by number and size of the solute molecules. This is in contrast with the osmolarity, as we know that this is determined only by the number of solute molecules in a given volume. But in most cases, urine-specific gravity increases linearly with increasing urine osmolarity, as we can see on this figure. So which means that when osmolarity increases, the urine-specific gravity also increases. This specific gravity is expressed as grams per milliliter, with a normal range of 1.002 to 1.028 grams per ml, which could rise 0.001 every 35 to 40 milliosmoles per liter increase in urine osmolarity. But remember that this relationship of these two is being altered by the presence of significant amount of large molecules in the urine, for example, the glucose and some antibiotics, which means that this may falsely suggest highly concentrated urine despite a normal urine osmolarity.
Now that we have fully understood the concepts of urine concentration and dilution, let us now discuss osmolarity. As mentioned earlier, increasing osmolarity of the body fluids above normal signals the posterior pituitary gland to secrete more ADH, increasing the permeability of the distal tubules and collecting ducts to water. This mechanism increases water reabsorption and decreases urine volume. However, it does not significantly alter the renal excretion rate of the solutes. On the other hand, excess water in the body and reduced extracellular fluid osmolarity cause decreased ADH secretion by the posterior pituitary, which reduces the permeability of the distal tubule and collecting ducts to water. Thus, increased amounts of more dilute urine is excreted. To further understand this mechanism, let us begin our discussion on osmolarity. Regulation of the ECF osmolarity and sodium concentration are closely linked because sodium is the most abundant ion in the extracellular compartment. Thus, the amount of sodium in the body is the prime determinant of ECF volume. Extreme variation in osmolarity causes the cells to shrink or swell, damaging or destroying the cellular structure and disrupting the normal cellular function. Regulation of osmolarity is achieved by balancing the intake and excretion of sodium with that of water. Plasma sodium concentration is normally regulated within the closed limits of 140 to 145 milliequivalents per liter, with an average concentration of 142 milliequivalents per liter. The osmolarity averages to about 300 milliosmoles per liter, and the osmolar substances must be precisely controlled because they determine the distribution of fluid between the intracellular and extracellular compartment. With sodium as the major solute and effective determinant of the osmolarity of extracellular fluids, the plasma osmolarity can be estimated from the plasma sodium concentration using the formula plasma osmolarity is equal to 2.1 multiplied to the plasma sodium. In conditions associated with renal disease, the contribution of two other solutes, glucose and urea, should be included in the formula to be more exact. Such estimates of plasma osmolarity are usually accurate and are within a few percentage points of those measured directly. Normally, sodium ions and associated anions represent to about 94% of the extracellular osmoles, with glucose and urea contributing to 3 to 5%. However, because urea easily permeates most cell membranes, it exerts little effective osmotic pressure under steady-state conditions. Therefore, sodium ions in the extracellular fluid and the associated anions are the principal determinants of fluid movement across the cell membrane. These are the mechanisms that control the amount of sodium and water excretion by the kidneys, the osmoreceptor ADH feedback system, and the thirst mechanism. On this slide, we can see the tables of the effects of each mechanism. However, in order to understand this, we must be able to learn the mechanism behind these effects. Please do click on the table of osmoreceptor ADH feedback system. To start our discussion on the osmoreceptor ADH feedback system, let us first discuss how ADH are produced. In the hypothalamus, two types of magnocellular or large neurosecretory cells function in the synthesis of ADH. These are the supraoptic and paraventricular nuclei. The supraoptic nucleus is located bilaterally to the optic chiasm and produces about 5/6 of the ADH, while the paraventricular nucleus, located adjacent to the third ventricle, produces about 1/6. Both nuclei have axonal extensions ending at the posterior pituitary. The ADH are packed in secretory granules at the nerve endings and are stored in the posterior pituitary. Osmotic changes stimulate the release of ADH to the circulation and rapidly responds in order to regulate the renal excretion of water. Now, what stimulates the release of this hormone? There are neuronal cells called osmoreceptors, which are excited by small increases in ECF osmolarity. They are found in the vicinity of the anteroventral region of the third ventricle, or the AV3V region, specifically at the subfornical organ and the organum vasculosum of the lamina terminalis. These areas lack the typical blood-brain barrier, allowing ions and other solutes to cross between the blood and interstitial fluid. Hence, these regions rapidly respond to changes or small increases in ECF osmolarity. Once stimulated, the osmoreceptors send nerve signals to the supraoptic nuclei and increase the secretion of ADH. They can also stimulate thirst and sodium appetite. This diagram shows the basic components of the osmoreceptor ADH feedback system for the control of ECF sodium concentration and osmolarity. When plasma sodium concentration increases, like in cases of water deficit or dehydration, The increase in osmolarity will cause the osmoreceptors to shrink, which causes them to fire and send nerve signals to the supraoptic nuclei, which will then relay the signals down to the posterior pituitary gland. This action potential stimulates the release of ADH, which is stored in secretory granules in the nerve endings. As ADH enters the bloodstream, it is transported into the kidneys where it increases the water permeability of the late distal tubules, cortical collecting tubules, and medullary collecting ducts. This will cause increased water reabsorption, hence conserving water with continued excretion of sodium and solutes in a concentrated urine, thus allowing the return of osmolarity back to normal. In contrast, in cases of hypoosmotic ECF, less ADH is formed, resulting to less water reabsorption and increased formation of dilute urine. This concentrates the body fluids and returns the plasma osmolarity back to normal. Now that we have discussed the osmoreceptor ADH feedback system, let us look at these tables. On the table on the left, you can see that ADH secretion can also be affected by other stimuli to the central nervous system. Nausea, for example, is a potent stimulus for ADH release, which can increase to as much as 100 times normal after vomiting. Drugs such as nicotine and morphine can also stimulate ADH release. On the other hand, there are also drugs which can inhibit the ADH release such as clonidine, haloperidol, and alcohol. The marked diuresis that occurs after ingestion of alcohol is partly due to the decrease in ADH. The osmoreceptor ADH feedback system is also associated with the thirst mechanism and sodium appetite. Before we proceed to the thirst mechanism, let us first learn the disorders that may occur in impaired ADH secretion, which could be associated with the ability of the kidneys to dilute and concentrate urine. Let us discuss the following abnormalities which can lead to the impaired ability of the kidneys to concentrate or dilute urine. So first is the inappropriate secretion of ADH. Too much or too little ADH secretion results in abnormal water excretion by the kidneys. Head injuries, infections, or congenital conditions can cause the inability of the posterior pituitary to release ADH. Central diabetes insipidus is a condition in which the distal tubular segments cannot resorb water due to the absence of ADH. This results in the formation of a large volume of dilute urine, which is the primary abnormality clinically observed in patients. Excessive water loss activates the thirst mechanism, and drinking enough water would prevent large decreases in body fluid water. However, in cases where fluid intake is restricted or one is unable to drink due to unconsciousness, severe dehydration can rapidly occur. Central diabetes insipidus is treated with the administration of desmopressin, a synthetic analog of ADH, and it acts selectively on the V2 receptors to increase water permeability in the late distal and collecting tubules. Next is the impairment of the countercurrent mechanism. Maximal urine concentrating ability requires a hyperosmotic medullary interstitium. Regardless of the ADH levels, maximal urine concentration is limited by the degree of the hyperosmolarity of the medullary interstitium. Third is the inability of the distal tubules, and collecting ducts to respond to ADH. Nephrogenic diabetes insipidus is a condition in which the renal tubular segments cannot respond to ADH either in normal or elevated levels. It is nephrogenic since the abnormality is in the kidneys. This can be due to the failure of the countercurrent mechanism to form a hyperosmotic renal medullary interstitium or failure of the distal and collecting tubules and collecting ducts to respond to ADH. In either case, large volumes of dilute urine are formed. Also, there are many types of renal diseases that can impair the concentrating mechanism, especially those that damage the renal medulla. In addition, certain drugs were also found to impair the functional ability of certain parts of the nephron. Diuretics, which act by inhibiting the electrolyte reabsorption in the loop of Henle can impair the function of this portion, compromising its urine concentrating ability. Other drugs such as lithium and tetracycline can also impair the ability of the distal nephron segments to respond to ADH. Nephrogenic and central diabetes insipidus can be differentiated from each other by administration of desmopressin. Absence of a prompt decrease in urine volume and an increase in urine osmolarity within 2 hours after injection of desmopressin is strongly suggestive of nephrogenic diabetes insipidus.
Now, we're done with the osmoreceptor ADH feedback system and its disorders. Let us now move on to the other mechanism that controls the amount of sodium and water excretion by the kidneys, the thirst mechanism, which is on the right side of your screen. Before discussing the table on the right side of your screen, which is the control of thirst, we should understand first the underlying process of thirst mechanism. To understand this, please click the picture of the thirsty boy. So where do the thirst mechanism begins? In the central nervous system, specifically in the hypothalamus, it contains the thirst center. These thirst center are the neural area with location same as that promotes ADH release. That is shown in the box or enlarged area on the picture on the right side of your screen. This thirst center is located anterolaterally in the preoptic nucleus. Specifically, evidences have shown that particularly it is the organum vasculosum of the lamina terminalis along the anterior wall of the third ventricle. An example on how this center would be activated will be when certain cells in the hypothalamus are stimulated by rising osmolarity of CSF or your cerebrospinal fluid. They cause the sensation of thirst. Therefore, it almost certainly is an area that functions as an osmoreceptor. Speaking of the osmolarity, we have this threshold for drinking. As we know, sodium is the primary determinant or the primary particle or solute that determines the concentration of the fluid. So if this sodium concentration increases, even if only about 2 milliequivalents per liter above the normal value, which is about, the normal value is about 135 to 145 milliequivalents per liter. So increase of only about 2 milliequivalents per liter with this, the thirst mechanism will then be activated. As what was mentioned on the previous slide, increased extracellular fluid osmolarity stimulates thirst. This is one of the most important stimuli. When one has a hypertonic extracellular fluid or increased osmolarity extracellular fluid, it causes intracellular dehydration in the thirst center, thereby stimulating those osmoreceptors in the hypothalamus, which then stimulates thirst. This will cause the diluting effect or diluting the previously hypertonic extracellular fluid and thereby returning osmolarity towards normal. Another stimuli is hypovolemia or decreased extracellular fluid volume, shown on the upper right of your screen. Hypovolemia or decreased ECF as well as a decrease in arterial pressure. This pathway is independent with the one stimulated by increased plasma osmolarity. In turn, we know that when there is a decrease in blood volume or arterial pressure, angiotensins and baroreceptors are being stimulated. Specifically, your angiotensin II is an important stimuli. Studies have even showed that they act on subfornical organ and organum vasculosum on lamina terminalis. As you may recall, this area is the thirst center. Their effects on thirst helps restore blood volume and blood pressure towards normal, along with the other functions of angiotensin II on the kidney to decrease fluid excretion. Other stimulus of thirst includes the dryness of the mouth and mucous membranes of esophagus, as we may have experienced. Another stimulus is the gastrointestinal and pharyngeal stimuli. Now, please click the arrow on the lower left to go back to the slides of mechanism that controls the amount of sodium and water excretion by the kidneys. Table on the lower right of your screen summarizes the known stimuli for thirst. As we have discussed, plasma osmolarity being the most important stimuli. When there is an increased plasma osmolarity, the thirst center will be stimulated, thereby increasing thirst. Together, the decrease in blood volume and decrease in blood pressure will also increase thirst. This decrease of BP and blood volume will then stimulate or will then increase the levels of angiotensin II in the blood, and this angiotensin II will have a stimulating effect, thereby increasing the thirst as well. Your dry mouth and the mucous membrane of your esophagus also increases the thirst. Decreasing the thirst is the opposite of that increasing stimulus, with the addition of gastric distension. So the two mechanisms that were discussed previously work in parallel to regulate ECF osmolarity and sodium concentration precisely. Through these processes and mechanisms that were discussed previously. To show the effect of these mechanisms, we have a graph here, with a red line representing the functioning osmoreceptor ADH feedback system and thirst mechanisms. It shows that even if a person's sodium intake increases, it has only small effect on plasma sodium concentration. Whenever one of the two mechanisms fail to function well, one can still control ECF and sodium concentration as long as there is enough fluid intake to balance the daily fluid losses. But if both fail simultaneously, the sodium and osmolarity are poorly controlled, such as that in the blue line on the graph on your screen. It shows an increased sodium intake resulted to large change in plasma sodium concentration. This happens because no other feedback mechanism is capable of adequately regulating plasma sodium concentration. Speaking of the effects brought by the failing of the mechanisms that controls the amount of sodium and water excretion by the kidneys, we have these problems commonly encountered clinically. The sodium disorders. Sodium being the primary solute or particle that determines the concentration of the fluid, or in short, osmolality. Therefore, this is affected when the mechanism fails. We have hyponatremia, which is a hypoosmolar disorder. This happens when plasma sodium is less than 135 milliequivalents per liter and is characterized with excess body of water relative to solutes. On the other side, we have hypernatremia, a hyperosmolar disorder. When plasma sodium concentration reaches greater than 145 milliequivalents per liter and is characterized with deficiency of body of water relative to the body solutes. Now, please click on the table to be able to go to the discussions of each type of sodium disorder. Hyponatremia, which is defined as a plasma concentration of less than 135 milliequivalents per liter, occurs in up to 22% of hospitalized patients. This disorder is almost always the result of an increase in circulating arginine vasopressin, or commonly known as ADH or antidiuretic hormone, and or increase in renal sensitivity to ADH, combined with intake of free water. This can also occur in patients with a very low intake of dietary solutes. Decreased plasma sodium concentration can result from loss of sodium from the extracellular fluid or addition of excess water to the extracellular fluid. So we have three subtypes of hyponatremia. We have hypovolemia, hyponatremia, hypervolemic hyponatremia, and euvolemic hyponatremia. The first figure shown on the screen are brain cell volume regulation during hyponatremia. Rapid changes in cell volume results from hyponatremia can have a profound effect on tissues and organ functions, especially on the brain. As seen in the figure, during acute hyponatremia caused by loss of sodium or excess water, there is a diffusion of water into the cells, and swelling of the brain tissue is indicated by the dashed lines. The process stimulates transport of sodium, potassium, and organic solutes out of the cells, which then causes water diffusion out of the cells. With chronic hyponatremia, the brain swelling is attenuated by transport of solutes from the cells. The next photo is a comparison of water volume. So underlying pathophysiology depends on the fluid volume. Again, hyponatremia is subdivided into three groups: hypovolemic, euvolemic, and hypervolemic. As you can see in the picture, the hypovolemic hyponatremia, both sodium and water levels decreased, but sodium loss is relatively greater. This commonly occurs due to loss of sodium-containing fluid, as in the cases of vomiting and diarrhea, especially when losses are replaced with plain water. In hypervolemic hyponatremia, there is an increase in total body sodium chloride that accompanied by a proportionately greater increase in total body water, leading to a reduced plasma sodium concentration. This often results from fluid retention and conditions such as heart failure, liver cirrhosis, and kidney failure. In euvolemic hyponatremia, this implies normal sodium stores and total body excess of free water. This occurs in patients who take in excess hypotonic fluid and combined with renal insufficiency or syndrome of inappropriate ADH or URSIAD-H. So there are three classifications of hyponatremia, and each has distinct features or states they are in. For hypovolemic states, the patient typically has increased jugular venous pressure, has crackles, is dyspneic, has wet cough, and lower extremities edema. Generally, there is a low serum osmolarity, low urine sodium, especially in chronic heart failure, cirrhosis, and nephrotic syndrome, whereas a high urine sodium in chronic renal failure and hypothyroidism. For the euvolemic state, there is no notable abnormality, for as the term implies, there's a neutral level of volume. And lastly, the hypovolemic state features increased thirst and dry skin, leading to dry mucous membrane and decreased skin turgor. Other features include low urine output, tachycardia, and hypotension. To discuss further the subtypes, click on the picture that represents the subtype of hyponatremia. Let us now discuss the causes of different types of hyponatremia, starting with hypervolemic hyponatremia. Hypervolemic hyponatremia is mainly due to the redistribution of water into the extracellular space. It is caused by several conditions, namely congestive heart failure, liver cirrhosis, nephrotic syndrome, chronic renal failure, and hypothyroidism. In congestive heart failure, there is a decreased cardiac output that leads to decreased arterial pressure, which will then result to increased thirst and release of ADH. This allows increased water volume in the body due to increased water intake and reabsorption of water, which then results in hypervolemic hyponatremia. In cirrhosis, there is an impaired albumin synthesis that leads to movement of water into the interstitial space rather than staying in the intravascular space. As we all know, albumin, being a protein, plays a major role or a big role on the oncotic pressure. So when this water moves into the interstitial space, it will cause edema. On top of it, there is also portal hypertension in liver cirrhosis, which decreases the cardiac output and ultimately leads to hypervolemic hyponatremia, as stated earlier. The third cause is nephrotic syndrome, in which, similar to cirrhosis, there is reduced level of albumin, but this time mainly due to the leakage in the glomerulus. Meanwhile, in chronic renal failure, there is a decrease in glomerular filtration rate that leads to RAAS activation, which then results in the release of aldosterone, which increases the reabsorption of water and sodium that leads to water retention. ADH is also released, which attempts to increase glomerular filtration rate by increasing intravascular volume of water, all of which will lead to hypervolemic hyponatremia. The last one, hypothyroidism, causes bradycardia, which leads to decreased cardiac output and decreased arterial pressure. It also causes decrease in glomerular filtration rate, which both of them contributes to hypervolemic hyponatremia. So let us now learn and click on euvolemic hyponatremia. Euvolemic hyponatremia is a subclinically volume expansion, so there is no edema. The most frequent cause is SIADH, or syndrome of inappropriate ADH secretion. There is a non-physiological release of ADH, which leads to increased expression of aquaporins or water channels in the collecting ducts of the kidneys. When there is an increased aquaporins, this will result into increased water reabsorption, thereby increased water retention and fluid overload, which in turn will make the heart release the natriuretic peptides ANP and BNP that, together with increase in glomerular filtration rate due to fluid overload, will decrease the activity of the renin-angiotensin-aldosterone system. The decreased RAAS activity causes decreased aldosterone, meaning there would be a lesser sodium reabsorption, and this would lead to natriuresis or increased secretion of sodium. But over time, there would be a renal adaptation in the kidneys, which will reduce the number of aquaporins and will eventually lead to diuresis. So this diuresis on top of the existing natriuresis will cause the euvolemic state. The other causes of euvolemic hyponatremia is beer potomania, chronic beer consumer that are malnourished, have low protein levels, decreased solutes, and have lots of fluid in their body. This leads to fluid overload and suppression of ADH, causing increased water excretion. Over time, the kidney will adapt and promote water and solute retention. This will then result in a euvolemic state. Please click on the hypovolemic picture and let us learn the causes and associated disease. There are several causes of hypovolemic hyponatremia. First is diuretics, mainly the thiazide diuretics. Their action is to inhibit the action of sodium and chloride symporter. This would lead to sodium loss and water loss due to non-existing effects of diuretics on the aquaporins. Natriuresis and diuresis are present. This results in hypovolemic hyponatremia. Vomiting can also cause hypovolemic hyponatremia by losing water while vomiting and losing acids also. The loss of water leads to hypovolemia, and the loss of acids leads to compensatory mechanism of the kidneys by secreting bicarbonate in the form of sodium bicarbonate, leading to sodium loss or natriuresis. Thus, hypovolemic hyponatremia happens. In hypoaldosteronism, this caused a decreased expression of sodium-potassium ATPase in ENaC channels. This leads to decreased sodium and water reabsorption that results to natriuresis and diuresis also. Thus, hypovolemic and hyponatremia happens. Diarrhea also leads to loss of fluid and electrolytes by the form of water and sodium bicarbonate, respectively. These losses leads to hypovolemic hyponatremia as well. Lastly, sweating causes loss of fluid, both water and electrolytes. Burns also cause loss of fluid from the intravascular space, and pancreatitis causes the transfer of fluid from the intravascular space into a third space that leads to hypovolemic hyponatremia.
For the clinical manifestations of hyponatremia, it is primarily neurologic. This is due to the development of cerebral edema within a rigid skull. Early symptoms include nausea, headache, and vomiting. A mnemonic that will help us remember would be salt loss. This includes stupor, anorexia with nausea and vomiting, lethargy, decreased tendon reflexes, lymph muscles for weakness, orthostatic hypotension, seizures or headache, and stomach cramping. For the diagnostic approach, clinical assessment should focus on the underlying cause of the electrolyte imbalance. And as presented in this diagram, a careful assessment of volume status is needed to identify the type of hyponatremia. Laboratory assessment should include plasma osmolality and urinary electrolytes or sodium levels. So when there is decreased total body water and a greater decrease of total body sodium, then we can say that there is hypovolemic hyponatremia. If both are increased, but increase in body water is much greater than sodium, then hypervolemic hyponatremia. If there is increased total body water, but more or less a total body sodium that is constant or normal, then it can indicate euvolemic hyponatremia. After which, levels of urine sodium concentration will then help us identify the specific cause of the imbalance. Now, in the management of hyponatremia, three things are to be considered. First, the presence and severity of symptoms. Next, the risk for osmotic demyelination syndrome in chronic hyponatremic patients. This is a condition wherein there is destruction of myelin sheath from nerve cells, which results from the rapid correction of hyponatremia. And lastly, the response to interventions. So with this, close monitoring is required due to unpredictable response to treatment. After assessing the possible considerations, one can now initiate interventions to manage the condition. In chronic hyponatremia, or those who present for more than 48 hours, fluid restriction has been the cornerstone of therapy, and the amount of fluid intake will be based on the patient's urine to plasma electrolyte ratio. A ratio of more than 1 would entail restriction of fluids to less than 500. If the ratio approximates to 1, restriction of fluid is 500 to 700 ml per day, and a ratio of less than 1 would be fluid restriction of up to 1 liter per day.
Potassium replacement can also be given in patients with concomitant hypokalemia. This will serve to increase plasma sodium concentration. However, aggressive repletion of potassium has a tendency to overcorrect sodium concentration, so it is important to be careful with this management. Next would be solute intake. This will serve to increase the ability to excrete free water or fluid without electrolyte. This can be done with administration of oral salt tablets or preparations of oral urea. However, it is still important to note that intervention should focus on the underlying cause of the condition. If those interventions fail to improve the patient, pharmacologic approach may be initiated. In chronic hyponatremia, this includes oral furosemide or oral salt tablets, demeclocycline, and AVP antagonists. So furosemide serves to inhibit the renal countercurrent mechanism and blunt urinary concentrating ability. So it increases the water, sodium, chloride, and potassium excretion, while the salt tablets counteract the excretion of sodium due to the diuretic. This is used for patients with euvolemic hyponatremia, specifically SiADH secretion. Demeclocycline is used for patients who does not respond to furosemide and salt tablets. This inhibits the action of antidiuretic hormone through blockage of binding of ADH to its receptors. Next would be the use of Vaptans. This is effective for patients with SiADH and hypervolemic hyponatremia. Vaptans are AVP antagonists, so they inhibit ADH. Available preparations for this includes tolvaptan and convaptan. Therapy with this drug must be initiated in a hospital setting without much fluid restriction, so more than 2 liters per day of fluid intake, and close monitoring of plasma sodium concentration is also needed. On the other hand, in patients with acute symptomatic hyponatremia, management includes the following: hypertonic saline solution. This acutely increases the plasma sodium concentration, which will help in the relief of severe acute symptoms of hyponatremia. Supplementary oxygen and ventilatory support is helpful for patients who develops acute pulmonary edema and hypercapnic respiratory failure. And lastly, IV loop diuretics will help treat pulmonary edema and promote free water excretion. Now let us learn more about diuretics. Diuretics increase the rate of urine volume output. As such, they are clinically used by decreasing renal tubular sodium reabsorption. This will cause natriuresis or increased sodium output, and in turn causing diuresis or increased water output. Thus, in most cases, increased water excretion occurs secondary to inhibition of tubular sodium reabsorption because sodium remaining in the tubules acts osmotically to decrease water reabsorption. Most diuretics also increase urinary excretion of solutes, especially sodium and chloride. Now, the most common clinical use of diuretics is to reduce extracellular fluid volume, especially in diseases associated with edema and hypertension. This is because loss of sodium from the body mainly decreases ECF volume. Therefore, diuretics are most often administered in clinical conditions in which ECF volume is expanded. So, as seen in the above figure, in steady states, urine output is equal to intake. But during diuretic therapy, some diuretics can increase urine output more than 20-fold within a few minutes after they are administered. However, the effect of this usually subsides within a few days due to activation of compensatory mechanisms initiated by decreased ECF volume. So an example of this would be a decrease in ECF volume may reduce arterial pressure. So to return it back to normal, there will be an increase in production of renin and angiotensin II formation. This will cause reduction in GFR, increased water reabsorption or water retention, and consequently increase the extracellular fluid volume. So all of these responses together eventually override the chronic effects of the diuretic on urine output. Shown in this table are the different classifications of diuretics and their mechanism of actions. First, we have osmotic diuretics. This decreases water reabsorption by increasing the osmotic pressure of the tubular fluid. So when substances that are not easily reabsorbed by the renal tubules, such as the urea, mannitol, and sucrose, are added into the bloodstream, this causes a marked increase in the concentration of osmotically active molecules in the tubules. The osmotic pressure of these solutes then reduces water reabsorption, flushing large amounts of tubular fluid into the urine. In disease states such as diabetes mellitus, when tubules exceed their capacity to reabsorb glucose due to blood glucose concentration rising to high levels, the remaining glucose in the tubules acts as an osmotic diuretic. This causes rapid loss of fluid into the urine. Therefore, one of the hallmarks of uncontrolled DM is polyuria, which is balanced by a high level of fluid intake due to dehydration, increased extracellular fluid osmolarity, and subsequent activation of the thirst mechanism. The next classification that we have here is the loop diuretics. They act as powerful diuretics that decrease active reabsorption in the thick ascending limb of the loop of Henle by blocking the sodium chloride potassium cotransporter located in the luminal membrane of the epithelial cells. So blockage of this cotransport increases urine output of sodium chloride, potassium, and other electrolytes as well as water. They do this for two reasons. First, they greatly increase the quantities of solutes delivered to the distal parts of the nephrons, and these solutes would act as osmotic agents to prevent water reabsorption. And secondly, they disrupt the countercurrent multiplier system by decreasing absorption of ions from the loop of Henle into the medullary interstitium, thereby decreasing the osmolarity of the medullary interstitial fluid. Because of this effect, the loop diuretics impair the ability of the kidneys to either concentrate or dilute the urine, and consequently, the reabsorption of fluid from the collecting ducts is decreased. So the maximal concentrating ability of the kidneys is also greatly reduced. In addition, decreased renal medullary interstitial fluid osmolarity reduces the absorption of water from the descending loop of Henle. These multiple effects causes 20 to 30% of the glomerular filtrate to be delivered into the urine, causing urine output under acute conditions to be as great as 25 times normal for at least a few minutes. For thiazide diuretics, they act mainly on the early distal tubules to block the sodium chloride cotransporter. So under favorable conditions, these agents may cause a maximum of 5 to 10% of the glomerular filtrate to pass into the urine. This is also about the same amount of sodium normally reabsorbed by the distal tubule. Next are the carbonic anhydrase inhibitors, which block sodium bicarbonate reabsorption in the proximal tubules. Because hydrogen ion secretion and bicarbonate reabsorption in the proximal tubules are coupled to sodium reabsorption through the sodium hydrogen ion countertransport mechanism, decreasing hydrogen reabsorption also reduces sodium reabsorption. This allows for sodium and bicarbonate to remain in the tubules and act as an osmotic diuretic. Now for the mineralocorticoid receptor antagonists, they compete with aldosterone for receptor binding sites in the collecting tubule epithelial cells. Therefore, they can decrease the reabsorption of sodium and secretion of potassium in this tubular segment. So since sodium remains in the tubules, they can act as an osmotic diuretic, causing increased excretion of water. These drugs are also referred to as potassium-sparing diuretics, since they can cause movement of potassium from the cells to the extracellular fluid, thus increasing ECF potassium concentration. Lastly, we have the sodium channel blockers. They inhibit sodium reabsorption and potassium secretion in the collecting tubules, similar to that of the MRAs. However, at the cellular level, these drugs act directly to block the entry of sodium into the sodium channels of the epithelial cells. Because of this decreased sodium entry, there is also decreased sodium transport across the cell's membrane, causing a decreased activity of the sodium-potassium ATPase pump. And as a result, there would be a reduction of the potassium transport into the cells and ultimately decreases the secretion of potassium into the tubular fluid. So for this reason, the sodium channel blockers are also potassium-sparing diuretics and decrease the urinary excretion rate of potassium. We are done with hyponatremia, so now let us click on hypernatremia. In contrast to hyponatremia, increased plasma sodium level is referred to as hypernatremia. It is defined as an increased concentration of plasma sodium to more than 145 milliequivalents per liter. It results from a combined water and electrolyte deficit with losses of water that is more than sodium loss. Causes can include reduced secretion of ADH or inability of the kidneys to respond to ADH, as seen in patients with diabetes insipidus. This results to excretion of large amounts of dilute urine, causing dehydration and increased concentration of sodium chloride in the extracellular fluid. Another cause would be reduced thirst mechanism. This can be seen especially in elderly individuals. So in these cases, hypernatremia can result due to little body water for the amount of total body sodium. For its clinical manifestations, the mnemonic fried salt can help us remember this. The patients can present with flushed skin, fever, restlessness, irritability, anxiousness, confusion, increased blood pressure and fluid retention, edema, and decreased urine output and dry mouth. Continuing, in the diagnosis of hypernatremia, assessment should again focus on identification of the underlying cause. This is through careful history taking to determine presence or absence of thirst, polyuria, or extrarenal water losses. PE should also include detailed neurologic exam and assessment of the extracellular fluid volume. As you can see in this slide, a diagram for the diagnostic approach to hypernatremia is presented. So, in the assessment of extracellular fluid volume, if it is increased, then administration of hypertonic sodium chloride or sodium bicarbonate is likely the cause of hypernatremia. If extracellular fluid volume is not increased, then serum and urine osmolarity is assessed. If there is excretion of low volumes of maximally concentrated urine, which is defined as less than 500 ml per day of urine with a concentration of more than 800 milliosmoles per kilogram, then extrarenal sources of water loss would primarily be responsible for the hypernatremia. On the other hand, in cases with increased urine volume, such as osmotic diuresis, urine osmol excretion rate would be more than 750 milliosmoles per day. This is due to the excessive excretion of sodium chloride, glucose, and/or urea. In contrast, if the urine osmol excretion rate is less than 750, then a test for the response to desmopressin is done. This is a synthetic form of AVP or ADH. This is used to help us differentiate if the cause of hypernatremia is central or nephrogenic diabetes insipidus. Lastly, in the management of hypernatremia, replacement of free water loss is initiated. Outlined in this table is the approach to the correction of hypernatremia. It is important to calculate all sources of water loss, such as renal losses and insensible losses from the respiratory, skin, and gastrointestinal system. And just to emphasize, the correction of hypernatremia should be slow to avoid cerebral edema. So this can be accomplished by correction of fluid for over 48 to 72 hours and avoidance of correction of plasma sodium concentration of more than 10 for 24 hours. Under normal conditions, the collecting tubules is impermeable to water with the help of ADH. However, in patients with diabetes insipidus, defects in the AVPR2 and AQP2 gene inhibit the binding of ADH to its receptors. Thus, luminal membrane of the collecting duct will render permeable to water. This will result to increased excretion of dilute urine. To compare the two types of diabetes insipidus, in central DI, there is a defect in the production of ADH, while in nephrogenic DI, there is a defect in the binding of ADH to the transporter. Nephrogenic DI can also result from secondary causes, which includes ADH resistance that affects the reabsorption of water. This usually results from loss of hypertonic medullary gradient as a result of solid diuresis or tubular damage. So due to the increased excretion of dilute urine, patients will present with polyuria with about 5 to 15 liters per day of urine output. This may lead to dehydration causing activation of the thirst receptors, and as a result, There will be a need to consume large volumes of fluid during the day, causing polydipsia. Nocturia can also happen from urgency to urinate during nighttime. For the diagnosis, serum and urine osmolality measurement should be obtained to be able to confirm and determine the severity of the disease. In the management of diabetes insipidus, our goals would include the following: to replace ADH, which is usually a long-term therapeutic program, to ensure adequate fluid replacement, and to identify and correct the underlying cause. Now, for treatment of nephrogenic diabetes insipidus, this includes maintenance of adequate fluid intake and access to free water by minimizing urine output through low solute load, low osmolar, low sodium diet, and medication. Replacement of vasopressin can also be initiated to promote fluid retention. Next, administration of thiazide diuretics can also be effective to induce sodium loss and stimulate proximal tubule reabsorption of water. Low salt and protein diet also help with water reabsorption. And if the condition does not respond to diuretic use, addition of endomethacin, which has additive effect in reducing water excretion, might be of benefit.
We are now done discussing urine concentration and the regulation of extracellular fluid osmolarity. Now, we are going to discuss pressure natriuresis. So why is this mechanism important? This is important because it is one of the most basic and powerful mechanisms for maintaining the sodium and fluid balance, along with pressure diuresis. It is also responsible for sodium excretion in our body. So what is natriuresis? Natriuresis is the increase in sodium excretion that occurs during an elevation of the blood pressure. So how does this work? We have a diagram here that shows a mechanism of it. We have different stimulus such as angiotensin II, aldosterone, and mechanical stress caused by high blood pressure, which then stimulates the production of the reactive oxygen species, or also known as your ROS. And this causes damage to the renal and vascular tissues, leading to the shedding of neoantigens. So, this ROS also promotes the release of chemokines and adhesion molecules from damaged tissues. Neogens are then presented by antigen-presenting cells or APCs to T cells within the thymus, which then egress towards the site of chemokines and adhesion molecule signaling, where they proliferate and accumulate. This event then results to kidney injury, vasoconstriction, and increase in sympathetic nervous system outflow, which perpetuates the hypertension and creates a cycle of injury and increasing blood pressure. Now, we are going to answer the question, when does pressure natriuresis occur? So it occurs in the renal body fluid feedback mechanism. This operates to prevent your continuous accumulation of salt and water intake. Also, it maintains your fluid balance and minimizes changes in your blood volume, extracellular fluid volume, and arterial pressure. Now, how does this mechanism occur? So this occurs if there is increased fluid intake. So assuming that with fluid intake, there is also increase of sodium intake. So if it is above urine output, then there would be a temporary accumulation of fluid in the body. Now, this mechanism works like this. So since there is fluid intake that exceeds your urine output, there would be accumulation of fluid in your blood and interstitial spaces. So, there would be increased blood volume, rising your mean circulatory filling pressure. And what happens next? It increases your pressure gradient for venous return. Thus, increasing your cardiac output. And once your cardiac output is increased, there will be also an increase of your arterial pressure. And once there is an increase of your arterial pressure, there will be increased urine output by the pressure diuresis mechanism. And if there is higher arterial pressure, pressure natriuresis might then occur in your body. So, with pressure diuresis and pressure natriuresis occurring, there would be increased fluid excretion, which then would release the accumulated fluid in your body. So in fact, the mechanism, the feedback mechanism, then prevents the accumulation of the fluid. But how does this occur? What are the hormones that affect natriuresis? Now we're going to answer the question, what other hormones affect your natriuresis aside from your ADH? So these are your ANP, your angiotensin II, and your aldosterone. So your angiotensin II is important in making your pressure natriuresis mechanism effective. Since if there is a high level of angiotensin II formation, it makes your blood very sensitive to sodium intake. However, when sodium intake is increased, it would require a greater increase of your arterial pressure also, in order to increase the sodium excretion and maintain sodium balance. Next, aldosterone is important since it also aids your pressure natriuresis in maintaining sodium balance. If there is a high sodium intake, it would suppress your aldosterone formation in order to decrease tubular reabsorption, which will then allow your kidney to excrete large amount of sodium. Lastly, your atrial natriuretic peptide acts on your kidneys to increase glomerular filtration rate, and it also decreases your sodium reabsorption by the collecting ducts. So what is its effect? So it increases excretion of salt and water to compensate for excess blood volume. Now, we are going to answer the question, what are the disorders that present with natriuresis? So these are your CYAD-H and your aldosteronism. So your CYAD-H, or also known as your inappropriate ADH syndrome, have patients that have excessive levels of ADH due to the abnormal vasopressin release from your pituitary neural lobe, which will then increase water absorption by your kidneys, diluting your extracellular sodium. The increased levels of your ADH does not cause major increase in your arterial pressure or increase extracellular fluid volume. However, this may still cause a small increase in your arterial pressure, so it can cause a loss of sodium from your extracellular fluid in the urine through your pressure natriuresis. So even though natriuresis and restoration of euvolemia have been done, but there would be still a worsening of your hyponatremia. Next, we have the aldosteronism. So, one syndrome under aldosteronism is your Conn syndrome. Since aldosterone has a powerful effect on your sodium reabsorption, the Conn syndrome can cause an excessive increase of your sodium reabsorption. This would then produce a decrease of your sodium excretion by your kidneys. So due to this increased sodium reabsorption, there would be an occurrence of sodium and water retention, which would then increase the arterial blood pressure. And after a sufficient increase in your arterial blood pressure, pressure natriuresis and pressure diuresis would then occur. This is then termed as escape, which is an escape from your sodium and water retention. And this is also the reason why Conn syndrome does not present with edema. So these are the disorders that present with natriuresis. To recap our discussion, we have ADH as our primary effector of urine concentration. So how does this regulate again? So if there is increased ADH, it would give you a concentrated urine, while if there is a decreased ADH, it would give you a diluted urine. So aside from urine concentration, it also regulates your extracellular fluid osmolarity and sodium concentration. So how? So it provides your osmoreceptor feedback mechanism and also has your thirst mechanism. And lastly, it also affects your natriuresis. So your natriuresis prevents your sodium body retention. We have now come to an end in our discussion. And once again, we are presenting our objectives that we had in mind before starting the presentation. We hope that you have understood our discussion, and we would like to thank all of you for listening. So that would be all.